So could I ask our speakers to join us up front? That should facilitate some questions. And if you have them, please go to the mic. I think I'd like to start the questioning process and pick up a point that Chris made, one that has worried me a little about the central IRB model. And I would pose this question to the other three speakers who spoke more or less in support of the central model. Is there a legitimate concern over atrophy of a local resource when those well-vetted, well-designed, important, methodologically rigorous studies don't show themselves very prominently at a local institution, but go back to a central resource? Will that cause atrophy in the expertise and ability of local investigators to see the state-of-the-art research? What do you think? Anybody but Chris.
I'll just make one comment about that, Steve. I mean, at least within the context of the NCI-designated cancer centers, of course, there is another review process, right? There's a scientific review process, which presumably continues independent of whatever the IRB model is. So, so from the point of view of the faculty in that institution, their opportunity to serve on such review committees, their opportunity to learn from that service and so on, that still exists. And of course, the adoption of the central IRB for certain kinds of research studies doesn't require dissolution of the local IRB. It only requires that the local IRB focus on other types of research.
Any other comments?
I would say that I agree that a better scientific review process and better discipline across service lines is what we've been thinking is the need. You know, I think a lot of this activity was located within an IRB inappropriately, and that the scientific review really needs to occur concomitant to this going for regulatory review in an IRB. So I think that in some ways outsourcing the IRBs gives more time and opportunity for more rigorous scientific review locally.
I agree with that. I also second Richard's point. It doesn't mean that there is no IRB locally, importantly. And I do think it will give the IRB more time to think about phase 1 and phase 2A and investigator-initiated trials, which I think is probably under-focused at the moment. So I also think that we need to differentiate the roles of the IRB office, as I mentioned. So I don't think that we will lose that expertise.
Okay. Chris, anything to add?
Yeah, I mean, I would agree. I mean, and we do, but most IRBs, I think at least our IRB spends most of its time on the 10% of the studies that require that attention to the investigator-initiated stuff, which is, you know, somebody with a good idea, but not been vetted in any community. But I may have misunderstood the question or what you all were saying, that if we're talking about cooperative group trials and use of the independent model, so the particularly late phase, there will be no local scientific review. Right? I mean, these, the trials that are fully designed and fully vetted have already had their scientific review, and they get a pass at NCI designated comprehensive cancer centers from requiring science. So there will be no scientific review. So the question about atrophy, I think, is a reasonable question. We're not going to see well-designed, fully matured phase 3 trial. I think that's what you're saying. Yes. And nobody in the institution will see those. And do we? Someone
not from the cooperative groups, but, you know, I mean, as you well know, you know, every cancer center has a portfolio of protocols, and as far as I know, that at least the industry-sponsored phase 3 trials still get you know, a more complete scientific review at the protocol review committees.
But they won't, presumably, if the ANPRM goes into effect, because the requirement will be that it won't just be, you know, the NCI and the cooperative groups deciding to use this because you're funded by the NCI. It will be that all institutions, all multi-center trials undefined, but if you've got more than one institution involved in your cooperative group trial, there's nothing for the local folks to do, including scientific review.
But that assumes that if I understand it correctly, that the learning occurs in the scientific review or IRB and processing a well-designed trial. You're going to be doing those trials as investigators, and you're going to be wrestling with, sort of the ethical quandary of more complex 10% of those trials. So I don't think you're losing expertise. So, I mean, it's just a difference.
Well, I think the question is at an institution level. So yes, the same 10% of well-trained clinical trialists will continue to be well-trained clinical trialists. But I think your point is that there's potentially that level of knowledge will remain with those isolated few and not presumably disperse over time down into what, ideally, what full-fledged cooperative group phase 3 trial should look like.
One of the things that we're doing is making sure that all of these studies go through a more complete clinical, operational, financial, and regulatory review before we sign off on them. So, it's typically one champion principal investigator that moves a phase 3 clinical trial forward, but as we're organizing our disease site service line groups, all of those people need to come together and review that, agree to it, come to some consensus, and really optimize all of those functions before I'll sign off on it. That's the way we've set it up.
Thank you. Let's take some questions from the audience, beginning on this side.
Hi, I'm Charlize Kaganen from the National Cancer Institute, and this isn't so much a question as an informational item. I don't know how many of you are aware in the room, but less than 2 weeks ago, NIH put out a funding opportunity announcement for empirical ethics research on 2 issues that are of relevance to this meeting. So the first is central IRBs, and the second is consent for research using clinical records and clinical data. So given the both the ethics and the IRB and all the experience in the room, please feel free to contact me. I'm the point of contact for NCI for that particular program announcement if this is something that you're interested in pursuing. I mean, it's clear that there's a lot of empirical questions that can be answered, or at least we can get some answers for, based on our discussion today.
Thank you. Holly?
Hi, Holly, Johns Hopkins University. So I think Chris partially answered my question in his answer. I was wondering, so as I understand it, NCI is currently covering the cost of the central IRB, and I don't know if, Barbara, you know whether the other NIH initiatives are being funded by the Institute, and whether we see that as a sustainable system. I guess to say, will at some point they act more like independent IRBs and charge institutions, or charge, how would one charge for this centralized review?
So NCI does cover the cost of its review. NINDS does pay and did enable NeuroNext IRB. The institutions do not think that it covers all the hidden costs, but that's true of every NIH grant that we're privileged to get. A number of the RFAs that are out now leverage the experience and say that there has to be single IRB review for multi-site trials, and there is no necessary funding for that. Within the Harvard consortia, we've tracked the reliance and the review and shown that they're pretty equal in terms of the number of times, over 90% of the overall PI is the institution of record. So yeah, you save all the other, institutional costs, but you would have had those anyway. And we've looked at how many times they're the same, and it's proportional to the number of faculty that they have involved. So it's sort of balancing out. Yeah. But you're right, it's not, these are costs.
Monica?
Yeah, Monica Bertagnelli, representing some of the two other aspects, I think, of the cooperative group viewpoint that haven't been brought up yet. One of them has to do with the issue of education and maintaining education at an individual institution. And one of the really huge mandates of the cooperative groups is exactly that, training and education of investigators. And if you're opening a protocol at your site, your investigators are participating in the cooperative group system, are going through educational modules that are all being provided by the groups, are going to sessions to debate the science behind the research. So it may be an institution's choice not to encourage their trainees or investigators to participate in the group activities, but certainly those activities are always available and highly encouraged to do exactly this, to make sure that we have very adequately trained workforce across the U.S. to be able to conduct this kind of research. So, that's one that may be worth a comment, the value of that to institutions and IRBs and their comfort that people are being educated. The second one is relates to the continuing review, and any large cooperative group trial, certainly all the phase 3s, but now virtually all of the phase 2s, undergo DSMB review at least once, sometimes twice a year, full DSMB review. So the IRBs are not flying and complete audits on anyone with, there's a huge audit trail to any of this work. So the IRBs are not in any way flying free of very thorough, detailed review of what's going on in any individual trial at any time. So interested in your maybe responses to those.
I would say that I agree with all of those comments. I think they're great comments, and I would say that our experience with working with many cancer cooperative groups shows us that it helps improve our expertise, our lifelong learning, our discipline for collaborating well with others, and debating complex issues and coming to consensus. So we really think of this as a primary tool for optimizing our cancer programs and configuring best standards of care and next best standards of care.
The point about data safety monitoring, right, in the most mature form of phase 3 trials is a data safety monitoring board, and IRBs rely heavily on them. We want to know in the continuing review, what did the most recent DSMB say? And so I think it does provide that. And cancer clinical trialists have led the way because of the risk associated with traditional cytotoxic chemotherapy historically, and they built the infrastructure to be able to collect that data and do attributions and do it well. And our studies do close early. Arms get removed. Speaking anecdotally, with regard to the central IRB, because those things have to move quickly, arm's going to get shut down, a trial's going to be terminated early. There are communications that go to research subjects directly from the cooperative groups without any form of IRB, local or central otherwise. And that may be okay. The communication's got to come. But I can speak again, it's anecdotally, if we're allowed to, that there have been some, even on the central IRB, who have had concerns, including the patient advocates, about how some of those communications are shaped, how they're framed, coming directly from the cooperative groups, directly to the research subjects, as opposed to being vetted more thoroughly by an IRB, with or without patient advocacy involved. So so DSMBs do their job, they do it well, particularly in NCI-sponsored or cooperative group-sponsored trials. And changes have to occur and have to occur quickly. And if you wait for 100 IRBs to approve the Dear Investigator, Dear Subject letters, the trial will long since have been terminated. It'll probably have been published by the time the last IRB gets that. But I'm not so sure that's an issue about IRB review times, as opposed to the ability to disseminate knowledge quickly to 100 IRBs at the same time. That's the challenge in that process. So.
I'd like to just give a little bit of specific information about one phase 3 melanoma trial that really elaborates on Chris's points because it really does speak to the fact that if you have a central IRB, you really do have to do detailed and intensive review to protect the patient. So an adjuvant melanoma trial done by ECOG looking at ipilimumab is a trial that you would definitely have to say this is a little bit of a higher risk trial because it's in the adjuvant setting, not the metastatic setting. And if ipilimumab is hurting patients, you really have to keep track of that. And there were 3 or 4 patient deaths in that trial that we didn't think were sorted out very well with the DSMBs, and we really dug into that. And that was a function of a really incredible review by Suresh Nair on the NCI Central IRB, and it promoted more accountability with that study group and also the DSMB to answer some questions that had not been answered well enough in that particular trial.
I want to add a footnote, Monica, to your valid question. Speaking as a methodologist, I've seen thousands of trials in my career, and many of them outside of cancer, which I count among the most valuable thing was to see trials, methodology, and become acquainted with those questions, even though I wouldn't be one of those investigators learning in the cooperative group setting that you outlined. Steve.
Very quick comment, Steve Jaffe from University of Pennsylvania. So a couple of speakers pointed out that one of the advantages of central IRBs is the ability to bring a kind of expertise together in one place that may be difficult for most, though perhaps not all, local institutions to muster. And I just want to advocate for central IRBs fulfilling kind of an educational and modeling function as they mature, that they have the ability both to have the sort of scientific and disease and clinical expertise and also the ethics and methodological expertise in one place. IRBs tend to be kind of black boxes. It's sort of hard to know what best practices are, what one IRB is doing well, what another IRB is doing not so well. And to the extent that central IRBs can both bring in people from the broader community who can learn from the experience of being members of the IRB and then go back to their home institutions and take that experience with them, and then also can be transparent enough to disseminate their lessons, to be able to develop a bit of a case law, which we don't really have in the IRB and ethics oversight world, and to sort of get that out to the community. They can really become models for improving IRB practice, both with respect to central review, but also with respect to local review and oversight.
Thank you, Steve. It looks like no comments. Wendy, and then we'll take the last 2 questions on this.
Wendy DeMark-Wanifried from University of Alabama at Birmingham. We really focused more on the clinical trials and therapeutic trials, and for behavioral interventions, for more observational studies that are involved with minimal risk. There's been some lip service to those, but this is an area where it seems that the central IRBs could really make an impact. A lot of time is spent in review in institutions and in minimal risk studies, particularly given the variability across the nation and the fact that these trials are often bumped up as far as the CYA element, and really they may not need as intensive a review as some local agencies may deem. It seems like that there could be a big contribution of central IRBs in that domain. So just a comment. I don't know how anybody else feels on this.
I would agree with that, and this is why I really said that you have to have operational and regulatory experts, like at the NCI Central IRB with John Horgan being so expert there. Our ability to increase the number of expedited and exempt reviews went up dramatically with that expertise. And the same thing happened at my local IRB when we brought the Carnegie Mellon expert there, because she wasn't running scared, being held hostage by the regulations.
So I completely agree. I also think that if we executed a master reliance agreement amongst most of these institutions, a common reliance agreement, then you get rid of the burden. And all you have to do is say, yes, we'll cede review. And you've done the paperwork and you've done the rest of all the, you've sort of papered it, as we say. After the Boston Marathon, there was an observation in Boston that there was an underappreciated hearing loss that occurred for all the individuals that were proximal to the blast. And one group at Mass Eye and Ear identified it and were interested in seeing all the local hospitals, whether we had seen anybody. And within 11 days, 8 institutions initiated the study. So because all of this structure was in place, now that was observational and collecting data, but not interventional, but it's trivial to be impactful.
I would agree. The devil will be in the details when it is minimal risk research, and particularly when consent can be waived. And it's 90% of the time it's easy to determine if it's minimal risk. 90% of the time it's easy to justify no need for consent. It's not, but that's mostly not where IRBs spend their time. It's about trying to determine if something really is minimal risk. So observational data on hearing loss in a population, the cohort population that's surrounding the marathon blast, presumably is something that's minimal risk. It's all existing data. The question about 5 years on, is that hearing loss still present, and the desire to want to go recontact those subjects. And so the challenges would then be at that point about having to, and should subjects be contacted now? I mean, it's obviously not the, but so the question about determining whether something is minimal risk is the challenge, and if it is indeed minimal risk. But obviously there are studies that approach that threshold, and there's a judgment call that gets made, and it can be difficult to know. And there is incentive on the part of the PIs to be below that threshold, to be below the threshold of minimal risk. If it is minimal risk and there's a centralized IRB that has the capacity to be able to review those and get it done, then obviously they should, though. No question about it.
I keep mentioning our director of research regulations at Allegheny Health Network as someone we recruited from Carnegie Mellon. Her name is Don DeFazio. I just wanted to say that.
Let's take the last 2 questions over here.
Yeah, Jeff Botkin, University of Utah. I want to ask about the constellation of activities that are involved with each study going through each institution. And several of you sort of touched on this, but I'd like some more feedback about how you're managing those situations. So particularly with oncology trials, we've got radiation safety that reviews those. We have a clinical cancer investigation committee that makes sure that there's not competing protocols for the same patient population and that we have staffing. There's a conflict of interest committee, and in a not too distant future, we'll have the institutional conflict of interest committee. So the IRB is not in our institution, the IRB is not the rate limiting step. It's actually much more sponsored projects that I didn't even mention. So all of these things have to happen before IRB approval. So, in part it's a plea consistent with Chris's argument. I think we have to measure that whole span and what's the marginal improvement in getting the IRB centralized when the rest of these committees to date have not been centralized and perhaps can't be. And the results of some of those committee reviews have to be reflected in the consent form in terms of things like conflicts of interest. So kind of interested in how institutions who've made a success of this are dealing with those constellation of services.
I specifically didn't use the term rate limiting step because I didn't have the data. I only had the experience. But I think that is the issue about this issue. It is this issue about time, trying to find the right metrics. And if the metric is to enrollment of the first subject, the IRB's contribution to that time, it's presumably not the rate limiting step. It's a contributor, no doubt about it. But those other things that have to happen, even once they've all happened, the ability to uptake the trial, to know the eligibility criteria, and to know that tomorrow when that subject who's potentially eligible comes in, that you need to get them, approach them and see if they're willing to enter the study. I mean, there's all those times that come into play. I don't know how many institutions have done this successfully. I mean, we'd have to ask the CIRB. I mean, the movement to an independent model, right? The CIRB existed in so many ways as facilitate 12,000 facilitated reviews. But in an independent model, the movement to a mandated independent model was 2013, and most institutions have not yet fully transitioned to that independent model. There are very few, I think, that actually have fully transitioned. Most have transitioned to. Including agreements to transition. And the initiative. And what proportion of were in the initiative? Sorry.
I can't tell you the proportion of institutions that are enrolled. I don't know that off the top of my head.
Okay.
But for those institutions that were enrolled, the number was somewhere around 300 institutions enrolled in the facilitated review model. At the end of 2013, all of those institutions had transitioned to the independent model.
One point I would make about all of those committees that Jeff talked about, I mean, we look at that as part of the fragmentation and siloing of all of our work in these various departments and divisions, and how hospital-based management can really silo things off. So what we're trying to do is harmonize all of these activities. So for example, at 7 hospitals, there's cancer committees at all of those hospitals, so we're trying to roll that up into an oncology integration steering committee and really promote more coordination and efficiency and harmonization. And each of those committees and each of those steps can take on a life of their own, and you really do have to merge them up somehow.
Okay, Rich, comment?
I was just going to make a quick comment on this whole issue of time. I mean, Chris is exactly right, and that the IRB review time per se is typically only a very small proportion of the overall time to enrollment. It's been well studied by David Diltz and others. It's been demonstrated that at least in most cancer centers, it's the contracting, not the IRB, that inserts the greatest delay into the process. But I do want to point out, and I've learned over the years to not often disagree with my IRB chair, but I do want to make one clarifying comment to Chris's comment previously about that it's not the time to the first patient, it's the time to the last patient that counts. Roughly a third of cooperative group trials historically fail to complete enrollment. And that's a huge waste of resources. And one of the driving factors in why they fail to complete enrollment is the time it takes to get to the first patient, not the time it takes to get to the last patient. And there's almost a linear relationship between time to the first patient enrolled and the probability of success in completing accrual. And it's largely because the science moves on while everybody's waiting to get the study enrolled. So this is a critically important issue for the whole community, is to compress to the greatest extent possible the time to get that enrollment going. And whether it's the IRB, the contracting office, the scientific review, or whatever, we have to look at all of the components of this process.
And I'll just add one small point. We don't hold up, or would not think to hold up, IRB approval for all those other processes. We hold up activation. So it's sort of semantic, but the IRB approval comes in when it's ready, and then we don't activate the trial at an institution until all of these pieces are fixed. It also gives you a better way of tracking the time and seeing where the problems are, to do it that way.
Yeah, but obviously as you measure the success of that system.
You need to use the microphone.
Well, obvious point perhaps, as you measure the success of your system, if you're measuring it to IRB approval, that's an underestimation of the system timing. So obviously you need to time it when the study is actually activated as opposed to when the IRB approves it. So it's sort of, I think, consistent with Chris. We have to be careful about what the terms are that we're measuring to demonstrate whether we're being successful with this experiment.
That's right.
Obviously,
That's right.
the IRB process for most, it is the most visible process in this. And I mean, it is possible that in the drive to change the federal regulations and those involved in producing the advance notice and the regulations that sooner or later presumably will be forthcoming, they actually really weren't aware of those other processes. The one they knew was the one that's most visible. The IRB time, the IRB review process takes too long, it's redundant, we got to do something about it. And they chose that because that was the gopher that was up out of the hole most of the time. Whereas those other gophers are much smaller, much more dispersed, nobody knows about it, COI issues were not as present, and they're increasingly so. And so I mean, I think that this notion about it all needs to get compressed, but compressing the IRB review times will be helpful, but other review times obviously have expanded, and they're to some extent more problematic, but they're a lot harder to get a hold of. I suppose IRB was relatively easy to get a hold of.
So
But OHRP
let's,
doesn't have oversight responsibility, doesn't have jurisdiction for those other things.
No, I know that.
So, you know, that's why the ANPRM isn't focused on it, so.
Let's move off this question. We have two other questions over here, and we're running out of time. Please.
Sue Anna Brunigy from the American Society of Clinical Oncology. One thing that Dr. Schilsky mentioned that I think is worth stressing again is that in the context of the cooperative group system, now the NCTN, that having that central IRB, I think, did raise, in a sense, the authority to change the protocol. Because I think when you have so many different local institutions, sure, you can make tweaks to the consent document or things like that, but to actually make what might be a substantive change in the protocol, it did give, I think, the central IRB that leverage to be able to say, you know, this needs to be made for the trial to open anywhere. So I think, and, you know, that coupled with Dr. Jaffe's point about, you know, the expertise, and literally, I mean, all of the people on the IRB are external to the institution as opposed to, you know, what the regs say. You know, I think it just has to be one or in combination with a different category. What struck me, Dr. Doherty, about your presentation is, in some ways, you're making the case that the University of Chicago is the ideal central IRB, because, you know, you didn't. What surprised me is it didn't come out, at least from my impression, that you were making the case that there were local context issues that justified the University of Chicago local review. You know, it seems like you're saying, you know, we do a really good job. We're the birthplace of a lot of these considerations, which is, you know, a point well taken. But especially in looking at these kinds of large, you know, phase 3 oncology, even phase 2B oncology trials, is it your sense that it's the local context issue that should be preserved, or what about the local aspect is worth preserving, or do you think is important here?
Well, local context has been defined for us, and many of those things are relatively administrative in nature. You must use thee instead of thou in our consent forms, kind of thing, right? And so a lot of those local context things are relatively straightforward. I don't think much is lost with regard to local context. I mean, there may be cultural issues within an institution and where it sits and the sensitivity to the community that surrounds it. It's definitely the case in the University of Chicago as an academic, tertiary, if not quaternary medical center that sits on the south side of Chicago, and how it's perceived by those in a 10-mile radius is definitely something that has to get taken into account. And I don't know what the repercussions are for an unanticipated problem that occurs on a cooperative group study in cervical cancer with an underrepresented minority who makes claims that they weren't informed about certain things in the local institution. It was not. I mean, it is this liability issue, and I understand that there are ways to deal with that. So I don't think it's necessarily local context as it's defined, but local culture as it might be outside of that. And again, my point is that not all IRBs are equal, and some presumably can do these jobs and do them well and still want to. Some don't want to and are grateful to have the burden relieved. And of course, in the end, right, any IRB actually, as each trial comes through, they have to process that protocol to some degree and make the decision. let it go and let the central IRB be the IRB of record, or keep it in-house, and presumably that will continue to happen. The phase 3 trials are probably going to be less of an issue. It will be as the earlier phase trials come through about how that's going to go.
One thing about phase 3 trials, though, that adjuvant melanoma trial that I mentioned, I think it really does address your point that we have 25 people on the NCI Central IRB, and it really did take a medical oncologist with some expertise in melanoma to pick that up, that all the rest of us that did those reviews didn't pick that up, and it did result in some rapid improvements by ECOG in that study. And the only other point is that when I showed that data that it took 100 to 200 days to activate a low-risk phase 3 trial, that's real data, and that's a real decrease in some potentially life-saving care for patients. We had a well-known cardiothoracic surgeon on our IRB who developed kidney cancer, and we were having a hard time. That was before we started reconstructing the IRB, and we were having a hard time getting some of the sunitinib and sorafenib trials up and running for these same reasons. And he actually, at the meeting, said, by the time you guys activate this, I'm going to be dead. I really think it speaks to Rich's point that, an IRB chair can shut something down, and that's, an unfortunate aspect of our human nature that you really, need to not get corrupted by the power aspects of it, and instead be of service and be accountable to your patients and your colleagues.
Okay, we're going to take the last question here from Barbara. Please be brief.
Yep, Deborah Collier. So we're hearing really good examples of IRBs, whether it's local or central IRBs. And I think that, and have heard that for the last couple of days. One question that I have is, how can we do a better job of giving IRBs all across the country best practices, more guidance to do the quality job that we're discussing here? And I guess I'll just leave it at that. I've heard the term, always before, central review, local oversight, and I don't know exactly how that fits into where our discussion is, or if that's an old concept that's not being discussed anymore. But it seems like there is still a need for local oversight, and that's what I'm hearing from the panel. It's just a matter of how is that going to be done with trials that may be centrally reviewed.
So thoughts from the panel in our closing 2 minutes?
Well, in the independent model, correct me if I'm wrong, but there won't be any oversight over those that go to a centralized IRB. But I think that there is, but institutions, whether they utilize the central IRB or not, the one thing that they are still responsible for are the investigators and their training, whether in human subject research or otherwise, and particularly in human subject research. So they will still have to prove, for instance, to the central IRB that their investigators have training in human subject protection. It's not the focus of this discussion today, but of course, for the most part, that training is either non-existent or superfluous. You go on a website, you click through the 3 or 4 modules, which you can, and the slides, and answer the questions, and most of us can get through those slides without having to read the content before the slide question. But that's the extent of human subjects training that occurs, right? So there are those of us who would say, really, we don't need IRBs at all to some extent. If we could find a way to get investigators educated and to keep that education up, you might not necessarily need oversight otherwise, other than over the individual investigators. So I think you are right. We do need better ways, but I have not seen resources put forth to do that or time cut out to do that. Not just for the IRBs, but I think for the investigators is equally as important, who would presumably serve on the local IRBs.
So I think there are two different points that you make. One is about training the IRBs and communicating best practices, and I think that's a very good point and a very good reminder. I think there are organizations like Primer who are doing their very best to communicate and to create a culture for and a home for the IRB administrative efforts. In terms of the people on the IRB, it is also one of the resources that's available. But it is a little bit of the individuals on the IRB, see one, do one, teach one, experience helps. I do think that there is always going to be local oversight. I don't think that anybody thinks that the central IRB then removes an obligation either of the institution or of the community practice or wherever to ensure quality care or quality human subjects research. And then in many ways, for instance, in the cooperative groups, they have an audit expectation for outliers just as we do institutionally. So I think that function remains. It's not and spelling out exactly who's going to do what and who has the permission slip to do what is important, but I think it's there.
Well, thank you. I think with that, we'll close session number 6, and with great thanks to the panel. So we're at the end of the workshop, and Dr. Bradbury is going to make some closing remarks. I'll say with my departure from the podium again, thank you all for your participation, and thanks again to the IOM and staff for organizing this great workshop. Angela.